So for today's podcast, we're going to be discussing the elbow, specifically the anatomy, kinesiology, and biomechanics as a review, moving into this region of musculoskeletal. Please review Dutton, 4th edition, chapter 17, pages 711 through 721 with any follow-up questions or concerns you may have over this content. So let's go ahead and get started. So again, this is a review of these content topic areas, and specifically we're looking at the elbow. First, let's talk about movement and normal range of motion. So in a neutral position, which is what we would consider to be approximately 90 degrees of elbow flexion, with a thumb up position, meaning neutral between supination and pronation. From that position, there typically is anywhere from 75 to 90 degrees of supination, as well as 75 to 90 degrees of pronation. As far as flexion and extension is concerned, there's approximately 150 degrees of flexion, though you will see some individuals have as much as 160 to 165, 170, and then 0 degrees of extension. However, many of our patients will present with slight hyperextension. 0 to 5 is fairly normal to be seen. When we're considering the joints of the elbow, typically 4 joints are discussed. However, we're going to discuss 3 joints at this time, the 4th joint being the distal radial ulnar joint. We'll talk about that when we get into the forearm and the wrist and hand. So the 3 joints of the elbow that we're going to discuss at this time are the humeral ulnar, the humeral radial, and the proximal radial ulnar. The humeral ulnar joint is what we really consider to be the hinge joint of the elbow, and it's the most commonly referred to joint at the elbow. It's a uniaxial hinge joint. The movements that we primarily see are flexion and extension, where the capsular pattern is greater for flexion than it is for extension. The closed pack position is extension with supination. The open pack is approximately somewhere between 70 to 90 degrees of elbow flexion, with approximately 10 degrees of supination or more that neutral position. For the humeral radial joint, this is a synovial condyloid joint. It as well is a uniaxial hinge joint. With this, we see a capsular pattern where flexion is also greater than extension. Here, the closed pack position is the elbow flexed to 90 degrees. The forearm is supinated to 5 degrees. The open pack position is full extension and full supination. Finally, we have the proximal radial ulnar joint. This is a synovial uniaxial pivot joint. This is where the proximal radial head is going to spin against the ulnar surface, and so the capsular pattern is equal between pronation and supination. Closed pack would be 5 degrees of supination, open packed slight supination of 35 degrees, and then 70 degrees of elbow flexion. Altogether, we call this a compound synovial joint. Here's a graphical depiction from Netters, where you can see the radiohumeral or humeral radial joint. Again, those are going to be used interchangeably depending upon what text you read. You may see variations there. You can see the proximal radial ulnar joint, where the head of the radius sits within the radial notch on the proximal ulna. And then you also have the ulnohumeral or humeral ulnar joint. Again, those are used interchangeably depending upon what text you view. So let's talk first about the humeral ulnar joint. It is a classic hinge joint. Within this joint, we do have a collateral ligament that is present. That is the MCL or UCL. MCL is the medial collateral ligament. UCL would be the ulnar collateral ligament. Again, those are used interchangeably. And with this, we have an anterior band, we have a posterior band, and then we have a transverse band. As far as these specific bands are concerned, the transverse band is probably the one that gets the most press, so to speak, as this is the one that helps to really limit the valgus stress that is applied to the elbow. We'll talk more about that as we get into differential diagnosis. The capsular pattern we've already reviewed. Open pack 70 degrees, maybe as much as 90 degrees. The closed pack is full extension, and there could even be a slight supination component with that. We also see the annular ligament of the radius that has some affiliation to this joint as well as biceps and triceps tendons that also will help to reinforce this joint. Overall, the humeral ulnar joint is a very, very strong joint. We should note as well clinically here that the trochlea of the humerus, based upon kind of the osteology, does have a slight spiraling effect, which will contribute to approximately 15 degrees carrying angle from one individual to the next, recognizing that females tend to have a slightly larger carrying angle and men a slightly smaller. This carrying angle is what we would anticipate to have the close relation to valgus. All right, and again, we'll talk about that more here shortly. Within the humeral ulnar joint, the clinical implications are also important to discuss. And so flexion is greater than extension when there is a loss. And so we need to ask ourselves, which loss has a greater functional consequence? Well, functionally, a small loss of extension will lead to huge consequences down the road. All right, and the big reason for this is if you begin to lose extension, you begin to lose the ability to fully straighten the arm. All right, and so this clinical relevance piece here with joint swelling and elbow flexion contractures is really important. This is taken from Oatis, the 3rd edition, the Kinesiology text. And it's important that we look at this. The clinical finding is consistent with the evidence suggesting that the tension in the joint capsule is minimized with the elbow flexed to 80 degrees. Right, so that's kind of that 70 to 90 degree range we were talking about. It is likely that patients then seek a position that minimizes the tension on the joint capsule, and so they adopt kind of this mid-range position. However, when they're in this mid-range position of flexion, in the presence of inflammation, it can result in adaptive changes in the surrounding musculature. And so we see this shortening of the flexor muscles, and so that can lead to a flexion contracture, as well as we see tightness that develops within the capsule. And so we need to be very mindful that when we're treating an elbow pathology where joint inflammation is present, it's critical to maintain not only joint function, but also to get back that end range extension. This is never more important than when we discuss the locked position. And the locked position is often utilized by those individuals who have a neurologic deficit, for example, a spinal cord injury or something else. And the locked position is a position that we can take advantage of, and we can essentially trick the motion where the hand is placed on a mat and then the muscles of the shoulder are used to pull the humerus forward. This allows the individual to put the elbow into full extension and lock it there. The lock will be on the posterior aspect of the arm. So what essentially occurs here is if somebody has a spinal cord injury, typically C6, C5, and they're unable to maintain integrity of the elbow extensors or flexors, but they do have integrity of the shoulder musculature, they can still lock the arm and utilize it for transfers. Kind of an interesting clinical note. So with this slide, hopefully you can begin to appreciate the carrying angle of the elbow, or that valgus component of 10 to 15 degrees. Note that it's the distal expansion of the trochlea on the medial side, or the ulnar side, that contributes to this slight angulation. And again, you can also appreciate the degree of varus that also can be present, and we would call that a gun stock deformity. Again, we'll discuss that as we go. Next, let's look at the radiohumeral joint. The radiohumeral joint is where the head of the radius articulates with the distal humerus. The stability of this joint is contributed to by the lateral collateral ligament. And here we have the lateral ulnar collateral band, the radiocollateral band, and then an accessory lateral collateral band. The function here is really to help with motions of flexion, extension, pronation, and supination. Again, we see a limitation of flexion greater than extension. Common problems here: fractures. We'll talk about that when we get to differential diagnosis and pathology, where you can actually incur an impaction of the radial head, as well as dislocation, which is referred to as nursemaid's elbow or pulled elbow. Again, we have a clinical note here. Really, if we did not have the radial head, our ability to bear weight would be rather poor. The radial head expands the weight-bearing surface of the proximal kind of elbow joint here. The radial head will also help to form a block to valgus stress. And so by having that radial head there, the MCL can kind of offload a little bit and has a bit of kind of extra assistance in terms of resisting the force of valgus stress. Here we can visualize the lateral collateral ligament. Note that the lateral collateral ligament is synonymous with the radial collateral ligament. Okay. We also have the annular ligament of the radius, and that annular ligament of the radius helps to hold the radial head against the proximal ulna where the radial notch would be found. With the proximal radial ulnar joint, again, stability is given there by the annular ligament. This is going to mainly function to help in terms of pronation and supination. The capsular pattern is equally limited for both pronation and supination. And here you can visualize that annular ligament again. Same picture of Netter, just with a different focus. So let's talk a little bit more about the ligaments as a direct focus. We've already discussed the MCL and the LCL and the annular. Let's talk a little bit about each of them individually. The MCL we've already discussed is a primary block to valgus stress. It is considered the most important ligament at the elbow in resisting valgus force, really from 20 degrees all the way up to 130 degrees, and it's primarily taught in extension. Why does this matter? Well, we'll talk here in a second about the clinical implications of this and its role in overhead athletics, so stay tuned. There are also anterior and posterior cords. Anterior is the most important of this ligamentous complex, and there will be some different ways that we'll assess this when we get to the objective exam. Note that the MCL is strengthened by the brachialis and triceps tendons, as well as helped out by the radial head. For the LCL, lateral collateral ligament, or even radial collateral ligament, there is some more variance than the MCL. It becomes taut in full elbow flexion, and it conversely is going to resist a varus force. The annular ligament resists the radial head distraction by again wrapping around the radial head. What's interesting here is it still allows for that true spin that occurs arthrokinematically during pronation and supination, and approximately encircles 80% of the radial head. Finally, one ligament we've not discussed yet is the interosseous ligament. This binds the radius to the ulna, helping to distribute stress between the radius and the ulna. Most of the tension when the radius and ulna are in the neutral position, and this is specifically important as you move distally down the forearm and you get closer to the distal forearm, wrist, and hand. Again, we'll discuss that a little bit further, specifically as we move from the elbow into the wrist and hand unit. So let's talk about the clinical implications then. So we mentioned that the MCL is helped by the radial head, and we also discussed that the anterior portion is really the most involved, and it's taught in extension. Well, the issue here is that when we have valgus stress on the elbow during pitching, the elbow is not in extension, and so that anterior band is not taught, thereby allowing the elbow to move into greater degrees of valgus. And so what happens here is that as overhead athletes, specifically those individuals who are pitching, are progressing from little league into collegiate play, minor leagues, and even all the way up to the major leagues, they are more or less creating a susceptibility of the MCL to micro trauma, which can then lead to macro trauma. And if the MCL is torn, oftentimes surgical intervention is necessary. The most common surgical intervention that we see is Tommy John surgery, and this was named specifically for the pitcher whose career was really saved by this surgery, Tommy John. And what happens here is the MCL is reconstruction. Typically, they take a non-relevant or non-necessary tendon from elsewhere in the body, typically palmaris longus or even plantaris, and they'll use that to reinforce then that MCL and tighten it, thereby allowing the elbow to resist that valgus force. Of specific note is the role that PT has in reducing the incidence of MCL involvement. We can work through education and through coaching our athletes that are seeking our services, parents who are putting their kids into various levels of sports, and even coaches themselves and leagues, educating them on the risk of high pitch counts and early stress to that ligament when the individual has not yet reached skeletal maturity. And again, we'll discuss this a little bit more as we go along. Let's review the arthrology now. So this is going to look specifically at the articular surfaces of the humerus, the radius, and the ulna. Note that the articular surfaces are angled at approximately a 45-degree angle from the shaft, which allows for full flexion with soft tissue space between the ulna and the humerus. If there is less than 45 degrees angulation, oftentimes this will appear as a hyperflexion. And so this may be where we see individuals who actually have more than 150 degrees of flexion. Conversely, if they have greater than a 45-degree angulation, these are individuals that will appear to have slight hyperextension, and so will actually go past neutral, maybe as much as 5, even 10 degrees. And so with these individuals, there's slight posterior displacement, and they may often lose some of their flexion. For these individuals, we typically will refer to this as cubital recurvatum. Moving into the myology, Netter has illustrated both the anterior and posterior muscles of the elbow and forearm. You can begin to appreciate the complexity of the forearm, all of the different muscles that originate from both kind of the common flexor tendon as well as the common extensor tendon. We'll talk more about kind of those medial and lateral origin and insertion points as they move into the forearm and wrist and hand as we get down there. Note that the big myology portions that we want to discuss for the elbow are specifically looking at muscles of the proximal arm into the humerus. So these would be things such as the biceps, long and short head, the brachialis, as well as the triceps and the anconeus on the posterior side. We do also want to consider some of those common flexor and extensor muscles, and we'll discuss those in a bit. Specifically, as we look at the elbow flexor muscles, again, we're looking at biceps brachii, both short and long head. We're looking at brachialis and brachioradialis. We're also looking at pronator teres. When we look at these four muscles and their interaction of muscle length and moment arm, we begin to see how various muscle length is implicated with elbow flexion angle. So for example, as we look at the first graph here, this would be the top left, we see that as the elbow flexion angle increases, the overall muscle length is going to decrease. Okay. Now as we move one over, we're looking at moment arm. And here the moment arm increases to a point and then begins to taper off as the degree of elbow flexion goes up. So once you get really at 100 to 120, it peaks for all of the muscles with the exception of pronator teres. All right. Now why does muscle length and moment arm matter? Well, it matters in terms of length-tension relationship, and that's the last graph that we want to look at here. And this here is where we begin to see and appreciate maximum force, or the position of greatest elbow flexion strength as it relates to elbow flexion angle. The sweet spot, as illustrated by this graph, is really 70 to 90 degrees. When you're below that or you're above that, you begin to taper off. And as you get to the extremes of range of motion, your ability to generate force is reduced. So if the elbow is too far flexed or too far extended, the length-tension relationship is not conducive to being able to generate maximum force. Here then is a muscle review chart where those primary muscles are reviewed in terms of extension and flexion of the elbow. So we have the triceps, long head, lateral, and medial head. That's the primary extensor of the elbow with root levels of 6, 7, and 8. We also do see the anconeus. It assists in elbow extension primarily from a stabilization standpoint, though not primarily. Biceps brachii, both short and long head, as well as brachialis. We did refer to in the previous slide the role of brachioradialis and pronator teres as well. And so if you want to review those, you certainly can. Recognize primary root levels here are 5 and 6. As you get into pronator teres and brachioradialis, you're going to have some involvement of 7 as well. Carrying angle. We've discussed this already. We recognize that it is implicated in terms of that medial distal portion of the humerus, and that it serves to direct the ulna laterally during extension, increasing the potential for elbow flexion motion. So it's actually giving us some mechanical advantage here. The midpoint distal to the humerus, as well as the midpoint proximal ulna, is really where our axes are going to be, both running medially and inferiorly. As far as the degree that we typically see, recognize that it is variable, and so we use a range here. For females, it's typically slightly larger, 10 to 15 degrees. For males, slightly smaller, 5 to 10 degrees. If we see greater than 15 degrees, we've typically referred to this as cubitus valgus, and if we see less than 5 degrees, we refer to this as cubitus varus. Note that if we see less than 0 degrees, such that valgus is actually not present, but actually varus is present, at this point we would refer to that as a gunstock deformity, and again we'll discuss that when we get to differential diagnosis. In our review of anatomy, we also need to discuss the cubital fossa. This is the anterior surface of the elbow joint, which is really kind of a triangular space, and it's an entryway to the forearm or the antebrachium. The contents include the distal biceps brachii, the insertion, the median nerve, We also find the brachial artery, which is a place where we can take a pulse. We find the radial nerve, and then finally we find the median cubital cutaneous vein. This is an important area when we're dealing with trauma due to the neurovasculature that runs through this area. And so anytime there are fractures of the distal humerus or proximal radius and ulna, one of the things that we need to be concerned about from a clinical capacity is whether or not these neurovascular structures have been harmed, injured, or disrupted. When we're discussing neural tissue, recognize that the median nerve passes between the humeral and ulnar heads of the pronator teres. And so that's one of the reasons why we talk about the pronator teres at the elbow. We will also discuss a syndrome called pronator teres syndrome, where the median nerve can actually become impinged in the periphery. That will be forthcoming. The radial nerve passes within the radial groove of the shaft of the humerus and then exits medial to the brachioradialis. Should there be a cause for concern in humeral fractures, one of the things we need to be mindful of is the implication of the radial nerve. And so when we're looking at the elbow, nerve innervation for the elbow really comes from C5 through C8 predominantly. And again, that's going to encompass really the elbow flexors and extensors. Finally, let's discuss the necessary elbow range of motion for most ADL completion. The ADL tasks or activities of daily living tasks are listed for you here on the bottom. Opening a door, carrying a pitcher, utilizing a chair, reading the newspaper, utilizing utensils at the table such as a knife or fork, picking up a glass and bringing it to your mouth, and or a telephone to the ear and or mouth. Recognize that some of these tasks have a fairly wide range of motion and some of them fairly limited. Note that none of them at this point really require 0 degrees as a sweet spot. However, from a clinical standpoint, we do know that some tasks require 0 degrees, and thus it's important for us to maintain that for our patients. The illustration on the left shows that really 0 to almost -5 or 5 degrees of extension, hyperextension, all the way up to 145 is really a sweet spot for being able to accomplish most activities of daily living. This is where our review of the anatomy, kinesiology, and biomechanics will pause. Again, take a peek at Dutton, pages 711 through 721 for more information. We will also have a podcast this unit on differential diagnosis and pathology, and so please take a look at that.